another patient. It's a young lady now, 40-year-old lady, past medical history of dyslipidemia, SLE, with predominantly lupus nephritis in remission, 2 miscarriages in the past, deep vein thrombosis of the left posterior tibial vein, on rivaroxaban 20 milligram, getting treated for a long term, so once daily, who presented to the office with 2 to 3 days of right lower extremity pain and swelling. Venous duplex shows, oh, there's a new DVT, popliteal and peroneal on anticoagulation. She does not have any other clinical symptoms, sign of pulmonary embolism, we just exclude that in our case. She denies any interruption in past 1 year, never stopped the anticoagulation, and then I can add that there is no medication interaction. So, and so she was on enoxaparin when initially diagnosed, and then they put her on rivaroxaban. Here we are. So we look at the chart, we look at the record. Patient has on prednisone, simvastatin, taking the rivaroxaban, weight is okay, and then she's a 28 BMI, 72 kilogram, creatinine is good, and nothing really comes to eyes. But you look back and say, oh, SLE, they checked this patient for lupus anticoagulant, last year when they were doing the workup for SLE, and patient is positive for antiphospholipid antibody, cardinal lipid antibody, and beta-2 glycoprotein. So this patient has antiphospholipid antibody syndrome. So briefly, it's a systemic autoimmune disease with either history of thrombosis or miscarriage. Usually you have established and persistent sort of elevation of the antiphospholipid antibodies, and that's what she has. She should have been on rivaroxaban to begin with because it increased the chance of failure. So how we treat this patient? So we have to take her off the rivaroxaban and start her on enoxaparin. I would think we'll go with this choice. So definitely bridging to Coumadin as an option, but we don't go any of those routes at this point. The moment that we can look at the chart and see that, oh, there was a positive, persistent positive antiphospholipid antibody. And this is where I see a consult, during my day when they call me like, Gene Collins and say, my graft is down, what's going on? So, and then I look and say, well, this is antiphospholipid antibody, that's why. So here, let's look at, there's the biggest meta-analysis that we have. This meta-analysis that we have is on a 447 patient with antiphospholipid antibody syndrome. So, and they treated with direct oral anticoagulant, 60% recurrence in 12 months. So they have a pretty high risk of recurrence. So, and especially the one that have a triple positive, because we have 3 categories of antiphospholipid antibodies: circulating anticoagulant, the beta-2 glycoprotein, and cardinal lipid antibody. The one that has all 3 positive, they have the highest rate, a 3 to 4-fold higher rate of the failure. So, multiple studies done, they couldn't prove that they can use the direct oral anticoagulant, sponsored by drug company and not sponsored by universities. They tried to make it a non-inferior, and that was the study. Rivaroxaban versus vitamin K antagonist in antiphospholipid antibody. They did a randomized non-inferiority trial to see that, okay, this is non-inferior. So it was an open label, but 190 patients, they put them on rivaroxaban versus vitamin K, and then they dosed it based on their renal function. So recurrent thrombosis on rivaroxaban was 11.6% compared to 6.3% on vitamin K antagonist, means Coumadin. So, and Coumadin family. So the conclusion was rivaroxaban did not show non-inferiority, even if you do the comparing to dose-adjusted vitamin K. So the take-home from this case is that the patient with positive antiphospholipid antibody are not a good candidate. I may put them on a direct oral anticoagulant if my enoxaparin or vitamin K antagonist is not my first choice. But it's not available, or I can't access it for some reason. Patient's condition is not allowing me to do it. But The first line, not going to be direct oral anticoagulant.